Good morning, everybody. I'm Howard Chansky, the chair of the Department of Orthopedics and Sports Medicine, and I want to welcome everybody to our September grand rounds. I hope everybody has enjoyed the summer and is going to squeeze a little bit more of it in the nice weather. I think that's coming up for the next week or so. We have a couple of announcements. First, our kudos. And I have a long letter from Craig Deppinger, who is the publications coordinator and also staffs the front desk at the academic offices for the Department of Ophthalmology at NJB, same floor as us. And Craig had a humerus fracture a while back and ran into me in the hallway and then sent me a letter to summarize what he told me. And just to be brief, he wanted to thank Zach Mills for the excellent care he got in the ED. He said it was a traumatic experience for him that day, and he really appreciated Dr. Mills' compassionate care. We don't typically have kudos for attendings, but Craig went on to thank Dr. Shu, and then also several of our APPs, including Kirsten Thompson and Connie Lee, for the care he got in clinic. And then I have a very nice note from Pam Turner, who's a nurse manager at the Harborview ED, and she wanted to thank Sarah Perkel. She said Dr. Perkel was on call in the ED last week, and the charge nurse and all three of the trauma nurses sought her out to tell her what an amazing job Dr. Perkel did. She communicated very effectively with the patients' families and took extra time with a particularly frightened patient. So thank you, Sarah, and thank you, Zach. There's a note from Dr. Wong about Dr. Bunzel, and Jerry wanted to pass along a note and said the patient was very appreciative of the great care that Eli provided and his incredible bedside manner. Thank you, Dr. Bunzel. And then I want to thank the residents I worked with most closely on the last rotation, and that's Dr. Prabhakar, Dr. Mills, and Arthur McDowell. I appreciate all of your help. You were all excellent. A couple of other announcements. We have quite a few new hires, which is always exciting, and I want to welcome them to their first grand rounds. Although for Dr. Corey Schiffman, he's obviously been at a few of our previous grand rounds. So welcome, Corey, who's joining the shoulder and elbow service. And then along with Corey, we have a new APP who's going to partner with him, and that's Lily Johnson, who's joining us from the Bay Area. Lily was working at one of the Stanford hospitals. Karina Kachko, you all know, one of our spine fellows, has joined us as a spine attending at Harborview. Also at Harborview is Erica Roddy. Dr. Roddy does not officially start for actually about 10 more days, but welcome, Dr. Roddy. We also have Dr. Sylvia Chu, who is a basic scientist who's coming to us from WashU in St. Louis. And Dr. Chu is going to be studying injury and repair of the tissues in the spine. Scott Yang is joining us from OHSU, and Dr. Yang is a new spine surgeon at Seattle Children's Hospital. Welcome, Scott. I think that's it. Today we're fortunate to have Dr. Kweon, one of our sports surgeons who takes care of the Huskies, and Joey Sliepka. Dr. Sliepka, as you all know, is one of our R4 residents, and I told Joey earlier that I always remember one or two things from interviews, no matter how long ago they were, and I'll always remember that Joey pitched at Harvard and then went to Italy, and he was a baseball coach for a while in Italy, although he said he sort of was a very part-time coach and spent most of his time having a great great time in Italy. And they're going to be discussing the thrower's shoulder from sideline to stadium. Dr. Sliepka, you're going to start.
Thank you, Dr. Kansky. Let me share the screen real quick. All right, I'll able to see my screen okay?
Looks good.
All right. Yeah, thank you, Dr. Chansky, for that introduction. For those that don't know me, my name is Joey Sliepka. I'm a fourth-year resident here at UW. Thank you for giving me the opportunity to present today at Grand Rounds. My presentation is entitled The Thrower's Shoulder from Sideline to Stadium, and special thanks to Dr. Kweon, who will be given the second half of this presentation. Dr. Kweon and I have no relevant financial disclosures. So here's an outline of my presentation. We're going to start with some background on the thrower's shoulder, then discuss some relevant anatomy and the phases of throwing. We'll then spend some time on what's known as the pathologic cascade, although I'd like to think of it more as the progression of physiologic adaptations that the body makes that can then become pathologic, and end with the tipping point between peak performance and injury. So let's begin. The thrower's shoulder has been studied for years and years. It consists of a sequence of highly coordinated events that we will discuss in more detail in just a few moments. As you can imagine, it places an extreme stress on the shoulder and its stabilizing forces. This is often thought of with regard to baseball and specifically pitchers, however, can be seen in all overhead throwing sports, such as in football, tennis, volleyball, handball, and track and field events. Next, we'll go over some of the relevant anatomy. The shoulder joint consists of the humeral head, which articulates with the glenoid, and a ball and socket articulation. It consists of static stabilizers, such as the labrum, which is a fibrocartilaginous structure that deepens the socket by about 50%. The superior glenohumeral ligament attaches to the anterior superior labrum and extends to the anatomic neck of the humerus. The middle glenohumeral ligament attaches to the anterior labrum slightly inferior to the SGHL and crosses the posterior aspect of the subscap and attaches to the humeral neck. The inferior glenohumeral ligament consists of two bands, the anterior band, which attaches to the glenoid rim anteriorly between the 2 and 4 o'clock position of the right shoulder, and the posterior band, which attaches between the 7 and 9 o'clock positions posteriorly, with a pouch connecting these two bands. They then come together and attach onto the humeral head-neck junction. The glenohumeral ligament attachment sites are shown in this figure here. There are some anatomic variants that are important to note when seen, as they do not represent pathology. A sublabral recess is a separation between the labrum and the glenoid superiorly. A sublabral foramen occurs when the labrum is not attached to the glenoid at the 1 to 3 o'clock position. And a Buford complex is an anatomic variant that consists of a complete absence of the anterior superior labrum, combined with a cord-like MGHL reported in about 1.5% of the population. These variants are illustrated here, and knowledge of these anatomic variants is important to avoid misdiagnosing them when these findings are present. Moving on to more dynamic stabilizers, we can start with the cuff. The rotator cuff consists of 4 muscles, the supraspinatus, infraspinatus, teres minor, and subscapularis, whose primary function is to provide dynamic stability to the shoulder by balancing the forces across the glenohumeral joint. The supraspinatus originates at the supraspinous fossa of the scapula and inserts onto the superior facet of the greater tuberosity and acts to initiate abduction of the arm. The infraspinatus originates at the infraspinous fossa and inserts onto the middle facet of the greater tuberosity, acting to externally rotate the arm. The teres minor starts at the lateral border of the scapula and inserts onto the inferior facet of the greater tuberosity and also helps externally rotate the arm in the abducted position. And then the subscapularis is the only anterior rotator cuff muscle, originating at the subscapular fossa and inserting onto the lesser tuberosity and acts to internally rotate and adduct the arm. In addition to the rotator cuff, the long head of the biceps tendon originates from the supraglenoid tubercle and curves around the anterior superior aspect of the humeral head inside the joint, coursing distally toward the bicipital groove. And then finally, the rotator interval is a space defined by the anterior border of the supraspinatus tendon superiorly, the coracoid base medially, and the superior border of the subscapularis tendon inferiorly. The contents of the rotator interval include the coracohumeral ligament, the SGHL, the long head of the biceps tendon, and the glenohumeral joint capsule. Together, when they function to prevent inferior translation of the humeral head when the shoulder is adducted, and posterior translation when the shoulder is abducted and externally rotated. So next we'll discuss the phases of throwing. The overhead throwing motion is one of the fastest movements in sport, with angular velocities surpassing 7,000 degrees per second. There's an image that we're probably all familiar with that illustrates the phase of throwing, so I figured I'd show some live examples while we discuss the different phases. So the phases of throwing start with the windup, which is the initial movement, starting with both feet on the ground and finishing when the ball is separated from the glove and the knee reaches maximal height. Early cocking starts from the end of the windup to when the stride foot contacts the ground. Late cocking starts from the foot plant to the moment when the shoulder is in maximum external rotation. Acceleration is the phase when from maximum external rotation to ball release. And of note, this is the shortest phase, but also the one where most injuries occur. Deceleration is the phase which occurs from ball release to when the arm is in maximum IR, and then follow through is the last phase, which starts at the end of deceleration and concludes when the arm stops moving. Next, we'll move on to what's known as the pathologic cascade. To me, this is actually a normal physiologic sequence of events that consists of adaptive changes that lead to maximum performance. However, when overdone, can lead down the road of injuries that we'll discuss in more detail. Briefly, the cascade consists of this general order, which we'll go through each step in detail to follow. In throwers, first there is a thickening of the posterior inferior capsule, which can lead to GERD or glenohumeral internal rotation deficit. Then there's a shift in the glenohumeral contact point, which leads to the clearance of the greater tuberosity, decreased cam effect, and hyperexternal rotation. And then finally, slap tears, rotator cuff damage, and internal impingement are the sequelae of these changes. First, thickening of the posterior inferior capsule. In the deceleration and follow-through phase of throwing, all of the energy in the kinetic chain is transferred to the upper extremity, which consists of distraction forces that can reach 1 to 1.5 times the athlete's body weight. These forces are resisted by the posterior structures, including the posterior inferior capsule and the posterior musculature. When this energy is not transferred appropriately, the posterior joint capsule can be overloaded. Repetitive tensile loading of the posterior inferior capsule leads to chronic attritional tearing, which in turn leads to hypertrophy and thickening of the posterior inferior capsule. This is a paper that was published in 2012 in the Journal of Electromyography and Kinesiology from a group out of Penn. They looked at baseball players to determine if there were unilateral differences in neuromuscular control, posterior capsule thickness, and stiffness secondary to repetitive throwing. By reviewing EMG and ultrasound findings, they found that the dominant arms of these baseball players had significantly thicker posterior capsules on ultrasound and then increased stiffness on EMG, concluding that these are adaptations made in repetitive throwers and that the posterior capsule increased thickness can lead to shoulder stiffness. This leads us to glenohumeral internal rotation deficit, or GERD. GERD is defined as the loss of internal rotation that is larger than the adaptive gain in external rotation. This is usually measured as a total arc of motion that is compared to the contralateral arm. As we've seen before, increasing posterior capsule thickness usually leads to a decrease in IR that is compensatory to the gain in ER. In addition to these soft tissue changes, osseous remodeling of humeral retrotorsion and glenoid retroversion can allow for increases in ER by allowing for a greater clearance of the greater tuberosity from the posterior superior glenoid, which we'll discuss in a bit. When the loss of IR is more than the increase in ER, this can put athletes at an increased risk of injury. This article examined the effect of humeral torsion and injury in professional baseball pitchers. This was published in AJSM in 2013 out of the Cleveland Clinic. This was a case control study that looked at 25 professional pitchers who received CTs on dominant and non-dominant arms. They found a significant association between lower levels of torsion and incidence of shoulder injury, potentially providing support for osseous remodeling and a parameter in the risk assessment in pitchers. Next along this cascade is a shift in the glenohumeral contact point. In the late cocking phase, the shoulder is in maximum external rotation and the posterior IGHL is inferior to the humeral head. If it is thick secondary to repetitive throwing, as we've mentioned before, it will push the glenohumeral contact point posterior superiorly, as demonstrated in this figure. This leads to clearance of the greater tuberosity and decreased cam effect. With regard to greater tuberosity clearance, the image to the right shows how a contracted posterior IGHL pushes the center of rotation of the humeral head posterior superiorly, allowing the greater tuberosity to externally rotate further than normal. And then with regard to decreased cam effect, a shift in the glenohumeral contact point leads to the humeral head no longer tightening the anterior capsule, aka a decreased cam effect. Together, these contribute to hyperexternal rotation. This is an article from JBJS published in 2005 out of UC Irvine. It examined the cadaveric models of throwing shoulders to determine the effects of capsular change. In this study, they took 10 cadaveric shoulders and a custom shoulder testing device that could take them through all ranges of motion. They then simulated anterior laxity by stretching out the capsule by 30% and posterior contraction by making a posterior plication, and then evaluated the humeral head translation in response to these changes. Capsular stretching led to a significant increase in external rotation, and posterior contracture led to a significantly decreased internal rotation. A posterior capsular contracture caused the humeral head to shift posteriorly, which led to maximum external rotation. As noted before, when the posterior capsule tightness is appropriately compensated with a shift in the glenohumeral contact point, this leads to greater tuberosity clearance and a decreased cam effect, which allows throwers to reach maximum external rotation, also known as the sweet spot. This results in maximum pitching performance. The most important factor for pitching velocity is the amount of ER that the shoulder can reach. And this clip illustrates an innocent bird realizing the consequences of reaching maximum external rotation. When these adaptation leads to maximum performance, that's great. But what happens when hyperexternal rotation leads to injury? The next steps of this cascade are what happens once definitive injury is encountered. In the abducted position, hyperexternal rotation changes the vector of the pull of the biceps that causes a torsional force at the base of the biceps transmitted to the posterior labrum. This leads to a peel-back mechanism of the labrum, detaching it from the glenoid, also known as a slap tear. There's an article published in AJSM in 1985 out of Tulane by Dr. Andrews that reviewed arthroscopy findings in overhead throwers. They observed that most tears in the glenoid labrum were over the anterior superior portion near the origin of the long head of the biceps tendon. They were able to confirm this by stimulating the biceps, causing a contracture that actually lifted the labrum off the glenoid. Their conclusion was that the twisting of the biceps tendon that occurs during abduction and external rotation causes a torsional strain to the biceps labral complex, resulting in a peel-back effect on the labrum. Excessive external rotation can lead to rotator cuff pathology as well. In much the same way as the biceps, excessive external rotation causes a torsional or twisting mechanism around the rotator cuff and can cause an undersurface tear, such as the one illustrated here. Together, these pathologies can lead to internal impingement, defined as when the articular-sided rotator cuff is compressed between the greater tuberosity and posterior superior glenoid rim and labrum. Under arthroscopy, you can often see articular-sided rotator cuff tears, as well as posterior superior labral tears, which, when encountered together, are known as kissing lesions. In the figure at the right, the orange arrow is pointing to the undersurface of the rotator cuff, and the green arrow, the posterior superior labrum, which have abnormal contact. Internal impingement is thought to be the most common cause of shoulder pain in throwers. This is a study published in the Journal of Shoulder and Elbow Surgery in 1992 out of France. They took 17 overhead athletes with shoulder pain and underwent arthroscopy. Under arthroscopy, the arms were placed in the abducted and externally rotated position, in which they were found to have impingement between the posterior superior glenoid and the undersurface of the rotator cuff. 12 patients had labral tears, and 8 of the patients had partial rotator cuff tears. They concluded that these lesions can cause impingement, leading to painful structural disease in the throwing shoulder. So along this cascade, the million-dollar question is, how do we keep players here and avoid being here? The short answer is we don't know. This brings us to the concept of the tipping point, where at any point along this cascade, these athletes go from performing at a high level to being unable to throw without pain. There's evidence to suggest that as many as half of asymptomatic professional baseball pitchers may have labral tears. So why do some hurt and others don't? It is unclear what breaks the balance between these adaptations and triggers the shift from an asymptomatic shoulder to a disabled joint. What we do know is that successful treatment depends on correctly identifying the source of pain, what phases of throwing in which the pain occurs, and where in the pathologic cascade the patient is in. This ends my portion of the presentation. I'll hand it over to Dr. Kweon. Thank you.
Thanks, Joey. That was great. I'm just gonna pick off right where Joey left off here. And when we're talking about the pathologic cascade, like Joey mentioned, I do think I agree. It's a physiologic accommodation of humans doing something that they probably weren't meant to do, which is to throw something as hard as they possibly can over and over and over again. And so when we're talking about when that tipping point has been crossed, some people talk about maybe it being when you start getting changes on MRI. So maybe developing something like this in your superior labrum on MRI scan. But like Joey mentioned, the presence of abnormal MRI findings is pretty high. In just regular people, it's somewhere in the 60% range of abnormalities in the superior labrum on if you take MRI scans of asymptomatic shoulders. And in the pitching or overhead population, it's actually probably more. And the same is true with rotator cuff disease. We know that there's some good surveillance data talking about presence of rotator cuff tears once you get above a certain age. And it's a similar thing or finding in overhead athletes in terms of having abnormal imaging of the rotator cuff or labrum if you live life with your hand above your head doing sports and recreation. So the tipping point, probably not related to changes on the MRI. And like you would think intuitively, the tipping point is basically subjective unhappiness. And the way in which these overhead throwing athletes present to us with their subjective unhappiness is basically pain. Pain, pain, pain. It hurts to now, and it used to not hurt to do what I used to do. And kind of distant third and fourth reasons for people being unhappy is having a not painful shoulder, but just not being able to throw as hard or throw as effectively or loss of control. So there's a couple reasons why people come in with subjective unhappiness about their throwing shoulder, but by and large, it's pain and how that pain affects their ability to be effective. But sometimes the pain is not there, but that's more rare. So talking about some of the surgical considerations, I think there's maybe like 3 points to sort out or to debate in terms of what to do surgically for a overhead throwing athlete once they reach that point, failed non-surgical management. You've tried to manage their load. You've tried the soft tissue stuff, rehab, rest, change the biomechanics, and you just get to this point where you have to start thinking about surgical options. And the main one I think to think about is whether you just simply clean up or take a minimalistic approach with debridement versus repairing the torn structures. What to do about the long head biceps tendon. I think Joey nicely pointed out a study that demonstrates that there's some involvement in the pathologic cascade in terms of what the long head biceps tendon does when it fires hard, which it does when you throw. And then what to do in the subacromial space. So outside the joint, there's debate among shoulder surgeons about what to do in the overhead throwing athlete and the subacromial space. So kind of hitting topic number 1, cleanup versus repair. Historically, we used to do repair. We're surgeons. So the CPT code for slap repair is actually kind of a newer code. It actually didn't exist before the 90s. And there was an explosion of slap repairs done in both the general population and in overhead thrown athletes once that code came into existence. And when looking more critically at the work that we did on pitchers, we found that the return to pitching or overhead sports after slap repair is pretty poor. And that it was similarly poor after rotator cuff repair, something in the 50-60% range. And this is backed by studies and just anecdotal evidence of surgeons who take care of high-level athletes talking at the meetings. And so in the last maybe 10 or 15 years, the move has been pretty clear away from repair of these structures in the overhead athlete and moving towards a more minimally invasive or limited approach with debridement or cleanup. And some early reports suggest that the return to competitive or same level throwing might be a little bit better than what it historically was with repair. And so taking all that into account, I think that less is probably more in terms of what you do with the superior labrum and rotator cuff in terms of debridement versus repair. Okay, what about the biceps tendon? The main consideration is whether, at least historically, was whether you debrided or did a tenodesis or did a slap repair for superior labrum / long head biceps tendon pathology. They obviously live right there. They're connected. They have an interaction. They're involved in this physiologic accommodation or pathologic cascade. And as we looked more closely at biceps tenodesis as a treatment for slap repair, we found that tenodesis did at least as good as slap repair, which historically was pretty bad. And then newer studies that talked about return to pitching after tenodesis being maybe quite a bit better than what we historically thought the return to sport was after slap repair. And when you're at the sports or shoulder meetings, I think when you do straw poll of shoulder surgeons that take care of baseball teams or track and field teams or volleyball teams, that there has been a stark move away from slap repair to either superior labrum debridement or more common biceps tenodesis. And that's kind of the practice that I've always had since I started at the University of Washington. I actually haven't done a single slap repair since I've been in practice. The last one I did was in fellowship. So I'm very heavily biased as evidenced by my practice habits, but I think the data suggests that the biceps tenodesis for long head biceps / slap pathology is at least as good, if not better, than slap repair. And for sure, the incidence or the treatment option being preferred for tenodesis is trending up. Okay, how about the subacromial space? I have no idea. And there's no good data. And we probably should just leave this topic for another grand rounds because it can really get into a rabbit hole. So we'll just leave this for Dr. Schiffman when he takes up his first grand rounds after he starts. Okay, some illustrative cases. These are cherry picked a little bit from memory that I pulled from the last couple of years, but they basically all have the same presentation. They're all overhead athletes that have pain and or reduced effectiveness throwing, reduced velocity, reduced performance. And they all have a physical exam with some vague anterior shoulder pain that may have some tenderness anteriorly, and all have positive O'Brien's testing. So all indicative of superior labral pathology. And they all have MRIs that kind of look like this or something pretty similar. And so here's a 21-year-old javelin thrower at UW, and he had positive Spies and Jurgensen's testing on physical exam in addition to the O'Brien's and general anterior shoulder pain. He had a really, really normal looking biceps and superior labrum, but some tearing of the more posterior superior labrum and extending a little bit more posterior inferiorly. And so we clean all that up and do that work to make it look nice and pretty. And the biceps looks really normal, but because he has a positive Spies and Jurgensen's, we take that biceps tendon down and remove it from the joint or where it attaches on the superior labrum. He has a pretty normal subacromial space, so not a lot of inflammation at all. We do a biceps tenodesis, and there's this kind of dealer's choice. Any technique that you want to do for this, it probably is good. And so again, clean up. No other signs that the shoulder is unhappy or is a pain generator. And the biceps look normal, but we did the tenodesis because of the physical exam, and he was happy. So got back to throwing javelin his senior year. Okay, softball shortstop at Pacific University. Same kind of presentation, positive Spies and Jurgensen's, really normal looking biceps, and really no tearing of the posterior superior labrum. So because of the physical exam, we did take the biceps tendon down, and here's the subacromial space that shows a really clean looking area without a lot of bursal inflammation and pretty normal looking coracoacromial ligament. And so not really any other evidence that pain is coming from anywhere other than the biceps, just based on the physical exam. So we did the biceps tenodesis and they're happy. Okay, pitcher graduated from Ingram High School and is going to be a pitcher at Edmonds Community College. He's got negative Spies and Jurgensen's testing and a really normal looking biceps and just a pretty normal looking supraspinatus and undersurface rotator cuff and a pretty normal looking superior labrum. He's got a little bit of fraying of the more posterior part of the superior posterior aspect of the labrum. and we cleaned that up a little bit, and he's got a partial tear of the subscapularis. And so we cleaned that up and looks a little bit better. And he's got a lot of subacromial inflammation and bursa that's inflamed. So we remove all that. And we think that he's got pain coming from that partial subscap and subacromial space. So that's all cleaned up and all the adhesions released. So we're pretty happy that we have an explanation of why he's got shoulder pain. And he had a negative Speeds and Jurgensen's and a normal looking biceps. So we just left that alone. So we did all the cleanup and normal biceps with normal physical exam, left that alone. Happy about it. He's terribly unhappy, feels like he still can't pitch, and we have to do all these things, injecting. We do cortisone and injecting the biceps, and maybe that's something we should have done beforehand, but made him feel good enough to be able to pitch. But basically targeted treatment for the long head biceps tendon is what allowed him to be a little happier compared to what we did for him at surgery. Okay, different left-handed college pitcher at Minnesota. He's got negative Speeds and Jurgensen's testing, but got the vague anterior shoulder pain, positive O'Brien's. He's got posterior superior labral tearing. He's got kind of this degenerative look of the superior labrum. So we clean all that stuff up. And I think to myself, I'm not going to get fooled. Fooled me once. And so we just take the biceps, even though he doesn't have the positive Speeds and Jurgensen's. And again, as a part of the treatment for his superior labral pathology. So there's his biceps that's gone. He's got some subacromial inflammation and bursa that we clean up. And we do the tenodesis. And so again, he had a normal looking biceps as far as can be inspected, but he's got that superior labral pathology. And despite the normal physical exam of the biceps itself, we did the tenodesis and he's pitching again, or got back to pitching. So taking all of these cherry pick cases in consideration, I think that in conjunction with the data, that we can comfortably say that for an overhead athlete, less is more. Kind of trending away from big repairs for the labrum and rotator cuff, I think is not consensus, but we're moving towards that. And whether, this is my opinion, whether the long head biceps tendon is a pain generator or simply an innocent bystander, I do think that shoulders seem to feel better when that thing is removed from the joint. So it's like the appendix in the shoulder, as far as I'm concerned, where the shoulders just seem to be happier when it is out of there and reattached somewhere else. And if there is superior labral pathology, I think that's a big kind of smoking gun in terms of the biceps either being a participant in that or a bystander in that pathology. And the throwing shoulder is no different. The understanding of subacromial space contributions and the response that people have to what we do up in there is not clear to me yet. And again, save that for hopefully a really insightful future grand rounds with someone. That's all I have. Thanks so much.
Thank you, Dr. Kweon, Dr. Sliepka. That was excellent. There's nothing wrong with being concise and thorough. And so we're left with a little, and I'm sure there must be some questions. Feel free to just turn on your microphone and speak up. I see a lot of shoulder surgeons on the call. They must have something to say. I see Dr. Belfi, Dr. Schiffman, Dr. Matson, Dr. Saper, Dr. G. I don't see Dr. Shu, Dr. Davies, Dr. Peterson.
I have a question, Howard.
All right, Dr. Lack.
I was wondering, this question for Dr. Kweon. For an athlete with a subluxating biceps tendon, so an injury to the tendon sheath, how do you treat that, and what athletes do you most commonly see that in?
Yeah, that is actually more rare to see in the in the overhead throwing athlete, at least in my experience. So, but I think the subluxating biceps tendon is a no-brainer. That needs to get tenodiced. And again, I've been branded a biceps killer. And I just think that it causes pain, and or it does stuff to cause pain, or it becomes painful when other stuff is happening around it. And I don't know if it's chicken or the egg, but I do think that when that biceps tendon is tenodiced, that people feel better. So a subluxating biceps tendon is a clear indication for tenodesis in my hands.
And
Yeah,
Chris, oh, sorry, Will, go ahead.
Oh, I was just going to say, yeah, I hadn't heard it discussed much in terms of overhead throwing athletes, and I wasn't sure if there was a specific group of athletes that it could occur in. But thanks, that's a good answer. Thanks.
Yeah, there is one group of athletes that notoriously is known for the subluxating long head biceps tendon, and that's softball pitchers. There's something about the throwing underhand really hard that predisposes people to that problem specifically.
My follow-up question to Dr. Lack was, obviously, if it's a subluxating biceps tendon, then you have a diagnosis. But otherwise, how often do you use diagnostic injections before you kill the biceps tendon?
If you're asking me, I probably should do more, but I don't do it very often because I think if you have anterior shoulder pain, tenderness over the groove, to me, there's like 7 qualifying things: the anterior tenderness over the groove, positive speeds, Jurgensen, a slap tear discovered on arthroscopy, redness of the tendon intraarticularly. So there's a lot fitting a specific demographic. I think there's a lot of things that qualify people earning the privilege of having their biceps killed.
Any other questions?
I have a question. I was gonna say,
Dr. Davies.
I was just gonna ask, what's your youngest patient that you would do a tenodesis in? Because this comes up now, and with the higher level pitchers at 16, 17, they're all convinced they're going to make it to the major leagues, and they have this type of, and they fail PT and they fail conservative management. You put a scope in there, and the biceps looks like that. How young are you doing tenodesis and not repairing a slap? And then have you seen, because I've seen a few where the slap is completely unstable and it's falling into the joint, and those are the ones I'll repair. But again, I don't repair very many at all because I don't think it's helpful to them. But what do you do with the 15-year-old or 16-year-old who has that pathology?
Yeah, I think I'm with you in terms of being nervous about, and I don't know where that age cutoff is. I think a couple of years ago that age cutoff was under 18, and that's that example that I showed where I did not do the tenodesis because he had just graduated high school, and then I did the tenodesis without really hesitation on the 20-year-old and the 21-year-old. So I don't know if I have a age cutoff, but I'm with you in terms of feeling nervous about taking down a completely normal appearing biceps tendon. But I think we could be reassured that there's data that's coming out of HSS and Rush and other spots that say that the return to sport is pretty good, and that the complication rate after a well-done tenodesis is pretty low. And so that's kind of what I've been tending to hang my hat on. But you're right. I don't know what I would do if a 16-year-old came in with a completely normal looking biceps. I know what I would do if it looked abnormal or shredded or red or messed up looking.
Chris, I don't know if you have a good answer for this. I feel like in my practice, I don't have a great answer for this either. Other than for college level athletes, especially the ones that we take care of, how do you know like when they've really failed PT? Because, like you said, I think we all agree that less is more when it comes to the painful throwing shoulder. We want to try to really maximize all the things that can be done with physical therapy, rehab, looking at their mechanics. And so I always find it's very difficult to know, when a high school kid comes that he's really failed all of that before, doing a scope that additionally may or may not help them.
Yeah, I would love other people's thoughts on this too. I don't think that I have some. I for sure don't carry around a specific number. You know, there's some people that talk about they need to fail 6 weeks or 3 months, and I think it's like you pointed out, it's probably more nuanced than that. I definitely have met the same parents where they bring in their kid. He has shoulder pain. He is on year-round select, plays for the high school. Oh, the one season he doesn't play, he's the quarterback for the football team in the fall. And so I think that it's a situation where we impart our own value system as to what has been a reasonable attempt to either manage the reps or do the rehab or try the alternative things. One of the measures or metrics that I use is if someone says I did 2 months of PT, I will, and if I have a sense that it wasn't enough, I actually ask them what changes occurred after the 2 months of PT. And so, and then if they have no answer, you know, I improve the range of motion by a certain amount on my internal rotation, or I felt like I got XYZ stronger with like my scapula stabilizers. And if they can't really point to something specific, then I will try to convince them that they haven't reached their PT or non-operative goals. But again, that is imparting like our own judgment or value system on it to some degree. So I don't know the right answer to that.
Yeah, I don't have a great answer either. Once in a while, I'll see if they'll come and see one of our PTs who I, can kind of who I've kind of worked with closely to on throwing type athletes to see if they have anything that they can kind of pick out that's been missing. If I'm really not sure, but most times I kind of go on what they've told me as well, and I don't have an absolute cutoff number either. I was just curious because I think it's always hard to know like what the quality of the rehab, the rest time, and all that has been. And I totally understand the idea of patients and obviously athletes who are eager to get back.
Question for Joey and Dr. Kweon, can follow up if needed. In that cascade, we know that there's going to be a little adaptive anterior laxity in the overhead thrower so they can get that extra rotation. Some of it's coming from the humerus and some of it's coming from the capsule. And that biceps is a secondary stabilizer anteriorly. And so as you know, I think we have to sort this out, but in your readings, do we have a sense of, which direction we're going? Is the biceps over engaged because it's under tension in that peel back sort of position, or is it being overworked as a secondary stabilizer because the soft tissue is loosening? I don't think surgically we want to tighten the shoulder up anteriorly. That's a death sentence for a thrower. But if we remove an anterior stabilizer from the joint, that's not fixing the problem of that of that anterior laxity. They're still going to be lax. So I think we're in this conundrum of what to do really with the biceps in these throwers, because I don't think we quite understand exactly what it's doing and how it gets injured. We're able to kind of see kind of where the data is taking us here in 2023.
Yeah, so thanks for that question. I don't have a good answer. From what I was able to see when reading about this topic, the laxity that they discuss with regard to the anterior capsule is almost described as like a pseudo laxity, where you get that based on the shift in the humeral head when the arm is in the abducted and externally rotated position. And so I guess if I had to like pick a side to be on, it would probably be on the one where taking the biceps is okay due to the fact that the peel back mechanism is causing pathology rather than its role as like an anterior stabilizer, just because it may, the laxity that you see anteriorly may not necessarily be due to like true laxity, more so than the actual shift in the contact forces at the joint. But I'll defer to Dr. Kweon and the other attendings.
Yeah, that's a great question. It kind of relates to, what Dr. Davies talking about in terms of the young thrower, the biomechanics and the involvement of the biceps. I don't know for sure, but I kind of think of it as it's like I don't want to say it's a nihilistic way to think about it, but I think that at some point the shoulder poops out. It's not able to make its accommodations or the physiologic changes enough to keep up with what the kids or adults are demanding of their shoulder. And I do think that the capacity to adapt is pretty high if you don't have pain, and so that's probably my rationale or thought process behind aggressive long head biceps tendon treatment anyways, is that if you don't have pain, people can be pretty effective. And the analogy is with little league elbow, where I think that the chronic or attritional tearing of the UCL is an adaptive thing of them trying to get more motion and torque in through their elbow as well. And so when you're doing a UCL reconstruction, it's acknowledging that their arm is pooping out to some degree. And I kind of feel the same with doing any shoulder surgery on a overhead athlete. So anything that can be done that most reliably gets rid of the pain, probably, even if we don't know the long-term implication of that, I think is kind of the only thing that's going to solve the short medium term thing, kind of like a UCL reconstruction.
Are there any other questions? Okay, well, thank you, Dr. Sliepka and Dr. Kweon. That was an excellent review of a complex topic. I hope everybody has a great day. Thank you.
Thank you.